You reach 70, and suddenly your doctor starts talking about various screening tests. Some you've been doing for years, others are new recommendations. And you start wondering, do I really need all of these tests? Are they helping me, or could some of them actually cause problems? These are exactly the right questions to ask, and the answers are more nuanced than you might expect. I'm a healthcare professional who spent years working with older adults, and today I want to have an honest, evidence-based conversation about medical screening after 70. Not about refusing all care or distrusting your doctors, but about understanding how screening recommendations genuinely change as we age and why. Because here's the truth. The decision about whether to continue certain screening tests after 70 isn't always straightforward. It depends on your individual health, your life expectancy, your personal values, and an honest conversation with your healthcare provider about benefits versus risks. This is about informed decision-making, not fear. It's about understanding the actual medical evidence so you can be an active participant in your own healthcare. Let's talk about what the research really shows. First, let's understand a fundamental principle. Medical screening works differently at different ages. When you're 50 or 60, many screening tests offer clear benefits. You have decades of life ahead. Finding disease early gives treatment time to work. The benefits typically outweigh the risks, but after 70, several factors change this calculation. Life expectancy becomes an important consideration. Many cancers grow slowly. If a screening test finds cancer that would take 10 to 15 years to cause problems, but your expected remaining lifespan is 8 to 12 years, the test may find disease you would never have experienced symptoms from. You also face competing health risks. After 70, you're statistically more likely to experience heart disease, stroke, or other conditions before a slow-growing cancer causes problems. This fundamentally changes the risk-benefit calculation. The risks from the procedures themselves also increase with age. As we get older, our bodies tolerate medical procedures differently. Sedation carries more risk, recovery takes longer, complications become more likely and more serious when they do occur. And perhaps most importantly, individual variation matters much more than it did at younger ages. A healthy, active 75-year-old with no chronic conditions is very different from a 75-year-old with multiple health issues. Generic age-based recommendations may not fit either person well. This is why major medical organizations have moved toward individualized decision-making for screening after 70, rather than blanket recommendations that apply to everyone. Let's look at what these organizations actually say, not exaggerated claims, but the real guidelines. For colorectal cancer screening, the U.S. Preventive Services Task Force recommends routine screening for adults aged 50 to 75. That's a strong, clear recommendation. But for adults aged 76 to 85, they recommend selective screening based on individual circumstances, and they recommend against routine screening for adults over 85. Now, this doesn't mean never screen anyone over 75. It means screening should be individualized based on several factors. Your prior screening history, meaning have you had normal colonoscopies previously? Your overall health status and life expectancy matter, and your personal preferences are part of the equation. The reasoning behind this is straightforward. If you're 76, you've had normal colonoscopies at 66 and before, and you have no symptoms, the likelihood of developing life-threatening colorectal cancer in your remaining years is genuinely low. Meanwhile, colonoscopy complications like perforation, bleeding, or cardiovascular events from sedation become more likely with age. But if you've never been screened, have a family history of colorectal cancer, or have concerning symptoms, the calculation changes entirely. The key point here isn't about refusing colonoscopy because doctors are trying to make money. It's about having an honest conversation about whether the test makes sense for your specific situation. When it comes to prostate cancer screening with PSA testing, the guidelines are even more specific. For men aged 55 to 69, the decision to undergo PSA screening should be individualized based on discussion with their doctor. But for men 70 and older, the task force recommends against routine PSA screening. The reasoning behind this is important to understand. Prostate cancer often grows very slowly. Many men have prostate cancer that never causes symptoms or threatens their lives. Autopsy studies show that many men die with prostate cancer, not from it. PSA screening can find these slow-growing cancers, which then leads to biopsies that carry infection risk, followed by treatments like surgery or radiation, which come with side effects including incontinence and erectile dysfunction. And all of this to treat a cancer that might never have caused problems in the first place. Now, if you have symptoms like difficulty urinating, blood in urine, or bone pain, or if you have a strong family history, diagnostic testing may be very appropriate. That's completely different from routine screening in someone with no symptoms. This isn't about ignoring prostate health. It's about understanding that after 70, routine screening in asymptomatic men may find problems that lead to harmful treatments for cancers that would never have threatened your life. For cardiac screening in people without symptoms, major cardiology organizations generally recommend cardiac stress testing or other screening for people with symptoms like chest pain, shortness of breath, or unusual fatigue. They also recommend it for people with diabetes or other high-risk conditions before starting intensive exercise programs. But they recommend against routine screening in people with no symptoms and low cardiovascular risk. The reasoning here is that screening tests in people without symptoms often produce false positives, findings that look abnormal but aren't actually dangerous. These false positives can lead to cardiac catheterization, which is an invasive procedure with real risks. They can lead to finding blockages that don't actually need treatment, stents, or interventions that don't improve outcomes, and medication side effects. Meanwhile, the test itself can occasionally trigger cardiac events in vulnerable individuals. What this actually means is that if you have cardiac symptoms, you should absolutely discuss appropriate testing with your doctor. If you have known heart disease, your doctor may recommend periodic monitoring. But if you're 73, feel fine, have no symptoms, and have low cardiovascular risk, routine screening stress tests may create more problems than they solve. Now, here's something crucial to understand. There's a fundamental difference between screening and diagnostic testing. Screening means testing healthy people with no symptoms to look for hidden disease. Diagnostic testing means testing people who have symptoms or concerning signs to figure out what's wrong. The guidelines questioning screening after certain ages are about screening healthy, asymptomatic people. They are absolutely not saying you should ignore symptoms, avoid investigating concerning changes, refuse all medical care, or distrust your doctors. If you have blood in your stool, colonoscopy may be entirely appropriate. If you have urinary symptoms or bone pain, prostate evaluation may be needed. If you have chest pain or shortness of breath, cardiac evaluation is important. If you have any concerning symptom, diagnostic testing may be essential. This is completely different from routine screening when you feel fine. Let me give you 2 examples that show why individualized decision-making matters so much. Consider Sarah, who's 77 years old. She's active, healthy, walks 3 miles daily, has no chronic conditions. She had normal colonoscopies at ages 57 and 67. She feels completely well. Her doctor discusses with her that continuing routine colonoscopy screening offers minimal benefit because slow cancer growth means any new polyps found would take 10 to 15 years to become dangerous, while the test carries real procedural risks that increase with age. After discussion, Sarah and her doctor agree to stop routine screening but monitor for any symptoms that would prompt diagnostic evaluation. This is appropriate evidence-based care. Now consider Robert, who's 76 years old. He has never had colonoscopy screening because he was uninsured for many years. He has a family history of colorectal cancer, but he's otherwise healthy with good life expectancy. His doctor discusses that despite his age, initial screening may be beneficial because he's never been screened, so there's higher likelihood of finding significant polyps. His strong family history increases his risk. His good health status suggests he'll tolerate the procedure well, and finding and removing polyps could genuinely prevent cancer during his expected remaining lifespan. After discussion, Robert decides to proceed with colonoscopy. This is also appropriate evidence-based care. Same age, completely different appropriate recommendations based on individual circumstances. So how do you have this conversation with your doctor? Here are the questions to ask about any screening test recommended after 70. First, ask whether this is screening or diagnostic testing. If you have symptoms, diagnostic testing is likely appropriate. If you feel fine, you're discussing screening and the calculation changes. Ask what the current medical evidence says about this test for someone your age and health status. Request that your doctor reference actual guidelines from organizations like the U.S. Preventive Services Task Force, not just what's routinely done. Ask what you're likely to find and what would be done differently based on the results. If the answer is that you just monitor it or that treatment might not change your outcome, the test may not be worth the risks. Ask about the specific risks of the test and any follow-up procedures and request numbers, not just reassurances. Ask specifically what the risk of complications is for someone your age. Ask, given your overall health and life expectancy, how likely is it that this test will help you live longer or better? This gets to the heart of the matter. Will the test actually benefit you, or are you more likely to experience harm? And finally, ask what happens if you choose not to do this test right now. Can you monitor for symptoms instead? Often, watchful waiting with attention to symptoms is a completely reasonable approach. While we're having these nuanced conversations about screening tests, let's talk about what genuinely does improve health and longevity after 70. Physical activity has enormous evidence supporting benefits for longevity, independence, and quality of life. Regular movement, whether that's walking, strength training, or balance exercises, matters tremendously. Nutrition is fundamental. Adequate protein intake, fruits and vegetables, staying hydrated, these basics have clear impact. Social connection is often overlooked but critically important. Isolation is a major risk factor for cognitive decline and mortality. Maintaining relationships and community connection is genuinely protective. Managing conditions you already know you have, taking medications as prescribed for high blood pressure, diabetes, or heart disease, this has clear evidence of benefit. Fall prevention becomes crucial after 70. Falls cause more disability and death than many cancers. Home safety, vision checks, medication review, and balance exercises are essential. Cognitive engagement matters too. Staying mentally active, learning new things, engaging in challenging activities, these support brain health. And quality sleep affects everything from cardiovascular health to cognitive function. These interventions have strong, clear evidence of benefit at any age, including after 70. The challenge in medicine after 70 is finding the balance between two extremes. On one side is too much medical intervention, over-testing, over-diagnosing, over-treating, causing harm through unnecessary procedures and treatments. On the other side is too little medical intervention, ignoring real problems, missing treatable conditions, failing to address symptoms that genuinely need attention. The answer isn't at either extreme. The answer is individualized, thoughtful, evidence-based decision-making that considers your specific health status, your values and preferences, your expected remaining lifespan, the actual likelihood of benefit versus harm, and what matters most to you in terms of quality of life. Since we're discussing screening decisions, let me briefly address how to identify unreliable health information. Be skeptical when you hear claims like, "Doctors don't want you to know this," or "the medical establishment is hiding this for profit." Be wary of blanket statements telling you to refuse all screening tests, or conversely, insisting everyone needs every test. Watch out for health advice that ends with selling supplements, claims that natural products replace medical care, or conspiracy theories about healthcare. Instead, look for information that references actual medical organizations like the U.S. Preventive Services Task Force, the American Heart Association, or the American Cancer Society. Look for nuanced, individualized recommendations that acknowledge uncertainty and complexity. Good health information encourages you to discuss decisions with your own doctor and separates health information from product sales. You have absolute rights as a patient. You have the right to ask questions about any recommended test, to request time to think about decisions, to seek a second opinion, to decline testing after informed discussion, and to participate actively in your healthcare decisions. What you're seeking is informed consent, genuine understanding of why a test is recommended, what it might find, what the risks are, and what alternatives exist. Good doctors welcome these conversations. They understand that medical care should be personalized, especially as we age. If you're over 70 and wondering about screening tests, here's what I'd suggest. Make a list of any screening tests your doctor recommends. For each test, ask the questions I outlined earlier. Research what major medical organizations actually recommend for your age group. Consider your own health status, values, and preferences. Have an honest conversation with your doctor about individualized decision-making. Then make decisions based on evidence, your specific situation, and what matters most to you. This isn't about refusing all medical care. It's about being an informed participant in your healthcare, understanding that more testing isn't always better, and recognizing that recommendations genuinely do change with age based on evidence. Medical screening after 70 requires nuance. The guidelines reflect genuine complexity in the evidence, not conspiracy, not profit motive, but real scientific uncertainty about when screening helps and when it might cause more harm than good. Your job isn't to blindly accept every test offered. It's also not to reflexively refuse all screening. Your job is to be informed, ask good questions, understand your individual situation, and make decisions in partnership with healthcare providers you trust. That's what evidence-based, patient-centered care looks like, and that's what will genuinely serve you best as you navigate healthcare decisions in your 70s, 80s, and beyond. Stay informed, stay engaged with your healthcare, and remember that good medicine is always individualized, never one size fits all.